PRN, although it's slow acting, wouldn't that make
yeah, so
some benefit?
aspirin keeps platelets from adhering, and the problem you're talking about when you have a massive PE is that you're going to pass that stage.
Right.
I'm not sure aspirin would necessarily hurt, but it's it's kind of like the horse has left the barn already.
Well, then that's part of the that's what we're doing for cardiac emergencies anyway.
ACS.
So what's the difference if we're suspecting it? I mean, not pushing that should be our protocol, but
well, it kind of is your protocol, right? Because these are chest pain patients.
Sure.
So these are patients you're going to be giving aspirin to anyway, because you're not going to know if they're having an MI or they're having a PE, even if they have a big swollen leg. So I'm not saying that's wrong. It's something most of these people are getting anyway. Not necessarily because it's the specific treatment for PE, but because these are chest pain patients, you're going to be giving aspirin to them. Does that make sense? Yeah, it's not one of the sort of specific therapies for PE. All right, anyone want to watch the surgical embolectomy? How much time do we have?
enough time to watch a video.
Oh, okay. Just hope it works.
Especially if there's blood.
There's a little bit of blood.
Yeah. Okay.
Is there anybody local who does that?
Someone at French might do it. I haven't had that happen here. You really need put someone on bypass to do this.
Because we had transported a patient with bilateral pulmonary embolism plus pulmonary embolism in his saddle, and he actually did have those EKG findings. Remember we did? Were you with me?
All right, it's a great video. I'll have to describe it to you.
Yeah, I don't know. Don't ask me.
Yeah, you can again Google pulmonary embolectomy. This guy's name on it. You can see a little YouTube video where they actually do it. You can see him pull this huge clot out.
Is that what Jess got in her jar?
And then
that was pleural effusion. Sorry.
And then they fill it retrograde. You can see that clot come out. All right. Any questions? You guys all feel well equipped to deal with every respiratory emergency you'll ever see.
So everyone.
So mission accomplished. Should we do a little break before the capnography thing?
Sure.
Okay.
Well, yeah. Like 5 minutes? Okay. Let me see if I think I can just come in.
That is a good video. But yeah, it's really gross.
You need a Chromecast just to cast it on.
Pausing.
Yeah. And so as you can tell, this isn't a minor surgery. This is something you kind of have to have the facilities to do.
So where's the closest office that would do this?
I don't work in prison. They need to do this.
So like,
It doesn't seem like.
It's the air that was trapped in there, and then they're doing retrograde filling.
That is amazing.
All right, you guys want to watch it again, or you're good?
yeah, one more time.
One more
Can you do
time.
the moments one really quick, just so we can get that on video?
Sure. Okay, now it's no brachial artery embolectomy. So you want Homan's sign.
There it is.
I'm scared to see what pops up here. Okay. All right, there we go. Since everything on the internet is here.
To perform the test for Homan sign, the patient is seated with the foot and ankle relaxed off the edge of the examination table. With the knee extended, the examiner passively dorsiflexes the foot and ankle. Pain in the calf indicates a positive Homan sign for deep vein thrombosis or thrombophlebitis.
And some people do it in a different position than seated. Some people.
They have a
And are we doing this one too? Or?
No, we're good.
We're good. All right. All right. Any questions about that? No. All right. You ready for a lecture on capnography?
Do it.
All right. So I was asked to talk about capnography because it's something important that people are going to be paying more attention to. And I was going to write the most amazing capnography lecture ever. But then I found this one on the internet and I stole it. So this is from Alameda County EMS, which is where I used to work. And Josh English wrote this lecture. And he actually wrote it a long time ago. And so I talked to him and I was like, hey, I found this awesome lecture you wrote. Can I borrow it? And he's like, sure, take it, have fun with it. So he was really happy to share this lecture. I changed a couple things that has some Alameda County protocols in it. But 99% of this lecture is the one Josh wrote. And he did all these animations by hand. He put a ton of time into it. So I think we should be really thankful that he's willing to share it with us.
We should share with him the one that Lori, Toby, and Dr. Giorgio created too.
Oh, okay. Yeah.
We could meld it into one super
It's not
PowerPoint.
broken.
The lecture to end all lectures.
Yeah.
But yeah, so he
Gold
was
standard.
very generous with this, so I appreciate it. And like I said, I just made some very minimal changes. So capnography. So the point of the lecture: understand why you use capnography, understand the physiology of respiration, ventilation. What's normal, what's abnormal, both in terms of values and the waveforms, which are more important. And then understand the major application of end-tidal CO2. There's something called mainstream and side stream, so the little things that you attach. So the mainstream one is the one that kind of goes where the BVM would attach or where the tube would attach. And then the side stream one is the one that attaches to the cannula. And there's some differences. The side stream one doesn't work that quickly. There's a several second delay on it because it's not getting the air that's going through, it's siphoning some off from the side. But the point of it is kind of the same thing. And again, if you have any questions, let me know. This doesn't show very well, but this is your capnography protocol, which is straight out of the protocol thing on the web page. But it just talks about the indication that says confirmation monitoring, documentation of intubation, and then assessment monitoring, documentation of respiratory status of the non-intubated patient experiencing respiratory distress, including but not limited to CPAP. There's no contraindications, and then the procedure talks about for intubated patients to confirm tube placement, and then for non-intubated patients to apply the side stream one and to continue monitoring it. And I think you're supposed to document when you apply it, when they have a change in status, and probably the end value. I notice you guys are starting to call up now, and part of your report is the end-tidal CO2. Any questions about the protocol? You guys probably know it better than I do. So why capnography? So the first use of capnography that we started to see in the field was to confirm tube placement. And there were a couple issues. One is to confirm that the tube got placed, and the other one to confirm that the tube stayed in place. There's been a lot of issues with EMS with movement of the endotracheal tube. I know where we used to work in Alameda, we had a few cases where someone came into the hospital and they had an ET tube that was improperly placed. Paramedics would say, well, I saw that tube go in, it must have gotten displaced when we moved them over to the hospital bed. The nice thing about end-tidal CO2 is that it provides an objective way to document that the tube's in there. If you have that normal end-tidal CO2 waveform all the way until you get to the back of the ambulance, the tube was in. It says no waveform, no tube. That's not entirely true. You can get some CO2 in the esophagus, so you can see a little bit of a waveform, but you're probably not going to see normal waveform with a normally placed tube. There's some cases where the tube will come out a little bit and it's sitting in the hypopharynx, so you're still going to get a waveform. You're still going to be ventilating. That's not a properly placed tube, but you're still ventilating if you're seeing the waveform. And I think that's the point of end-tidal CO2, that it. Pulse ox will tell you about oxygenation, and end-tidal CO2 will tell you about ventilation, which is not the same thing. There's no better way to confirm proper tube placement than with capnography. And I think since 2010, it's kind of been the standard of care in ACLS. But yeah, it's supposed to be the standard of care, and I think everyone is sort of used to it by now. Any questions on that? So it's a great thing. I'm glad we had it. So this is kind of talking about that. Why capnography? Respiration, ventilation, oxygenation, they're different things. And so this isn't just duplicating what you're seeing on the pulse ox. This is giving you entirely different information. So it's a window into the patient's ventilatory status. So there's two waveforms. There's one on the top. There's one on the bottom. Which one of those is hypoventilating? Yeah, and who's hyperventilating? Yeah. And they both have waveforms that tell you that you're getting, doesn't tell you they're intubated or not, but you're getting the information. So core concepts, what intubation verification method is most reliable? How do oxygenation and ventilation differ? So he made this whole animation, which I thought was pretty cool. Did you guys ever get that thing in paramedic school? The air goes in and out, blood goes round and round, oxygen's good, blue is bad. So it's kind of a more complicated version of that. But basically you have the lungs, your lungs, the primary function, you get blood going in there, you get air going in there. And so the function is gas exchange. You're trying to get oxygen into the cells, and you're trying to get CO2 away from the cells. So you're breathing in, oxygen goes through the lung, it goes into the alveoli, diffuses from the alveoli to the red blood cells. So there's the oxygen in the red blood cell, and then it gets carried around in your blood vessels. I know, he did this whole thing. Yeah.
In the end, though.
It goes into your muscles, you use it up, you still have the blood, but now you have less oxygen in it, you have more CO2 because it's picking up all the waste. So I think that's mitochondria. I had a hard time telling you what that was. So you have that whole oxygen plus glucose equals energy. You make all that CO2. Now you see that CO2, it goes in the vein, it goes back into the lungs, it goes into the alveoli, and it comes out through your lungs. Isn't that cool?
This was obviously designed for EMTs and paramedics.
Look
how long look how long med school would be if it was done this way. No. Another picture, please.
And so then the CO2 coming out is what you're seeing on the end-tidal CO2 waveform. So you're kind of seeing the end product of this whole thing. As the CO2 comes out the mouth, you pick it up on the detector, and that's what you're seeing on the waveform. He drew all these by hand. There wasn't like an app that did this. So factors that affect CO2 levels. So if you use your muscles more, you're going to make more waste products, or if you're hypermetabolic because of fever, because of malignant hyperthermia, things like that. CO2 level goes up. If your cardiac output goes up, so one of the things the Heart Association is talking a lot about is return to spontaneous circulation. You're in the middle of doing CPR, suddenly the end-tidal CO2 shoots up. That's one of the early indicators that you've got spontaneous circulation back. For drug therapy for bronchospasm, so the bronchospasm is getting better, then your CO2 might get better. And then hypoventilation, if you think about it, you're making a set amount of CO2 per minute, but if your respiratory rate goes down, then the amount of CO2 in each breath is going to go up. And then decreased CO2, sort of the opposite. So this is the normal end-tidal CO2 pattern. Do you guys know what the different parts of the waveform are? Who wants to tell me? Anyway, I think we have them labeled here. Okay, well, we'll get to that in 1 second. So he talks about a capnogram and a capnograph. So a capnogram is the waveform, and a capnograph is the waveform plus the numerical value. See, look at all those animations. And then end-tidal CO2 is a measurement of the CO2 in the breath. Technically, end-tidal is at the end of the breath instead of CO2, which you're measuring throughout the whole breath. And 35 to 45, probably. So this is a normal waveform. So CO2 goes up on the y-axis, and then time on the x-axis, and then it gives you a number. And so the first part of the waveform is the end of expiration. So when you're done with your expiration, how much CO2 is coming out? None, right? Because you're not, so you're breathing in, then you start expiration again after you're done breathing in. So B is at the beginning of exhalation. As you start breathing out, your CO2 starts going up. And then you get this sort of alveolar plateau where the CO2 goes up and up and up as you're sort of getting that oxygen or the CO2 that's deeper in there. And then when you stop seeing it, that means you're done exhaling again. And then it comes down, and then you do another breath. So you breathe in, your CO2 goes down. So this is kind of the cycle you're going to see with the end-tidal CO2 waveforms. And some people that really get into capnography look at the different things. They look at the slope of the plateau. They look at the shape of the curves. And that's not something, we'll talk about a couple examples, but I don't think that's something that's as important as sort of what each phase is, what a normal waveform looks like. And then, I think what's even more important is the trend that you're seeing. I think the usefulness comes less in sort of what it looks like initially is what the trend is with the treatment. In the hospital, we use this a lot for procedural sedation, which is not something you guys do. But when you're, giving someone medicines to sedate them, like you're reducing a fracture, doing a procedure. Capnography is great because, you're giving someone a bunch of medicine and they stop breathing for a second. If you pre-oxygenated them, it could be a few minutes before the pulse ox goes down. But with the capnography, you're going to see it within a few seconds. And then you can sort of decide, did I give them a short-acting drug, or, am I going to wait this out? Am I going to ventilate them? But it sort of gives you an advance warning. One of the issues that happens more in hospital is that we check the pulse ox a lot, and everyone knows what the pulse ox value is. But we don't know what the CO2 is. And one of the things that classically happens in hospitals is that, someone's getting sedated, they have a lot of pain, they're getting morphine, their oxygen level goes down, so the nurse will appropriately put them on oxygen. They're getting more pain medicines, the oxygen level goes down, they put them on more oxygen. And so the oxygen value is perfect, but what's also happening is their CO2 is going up and up and up. And if you're not watching their CO2, you can get in trouble where the CO2 gets so high that they get kind of tired and they don't want to breathe anymore, even though they had a normal oxygen. So, and the CO2 is really important because it's sort of the other side of the ventilation oxygenation thing. Any questions about that?
So your value comes from basically the D point.
Yeah, so I think the number is supposed to be the end-tidal, so it's supposed to be the highest part of the plateau. All right, and that's what a normal waveform looks like. We just went over that. And so here's a couple abnormal waveforms. So the top one is hypoventilation, so you see the number for the CO2 value is higher. And you just see the shape of the waveform is different. This guy is, spending a long time inhaling. There aren't that many breaths per minute. The respiratory rate's 8. And this one's hyperventilation. So the value of the end tidal is lower because, you're producing the same amount of CO2. You're just getting rid of less in every cycle because you're cycling so quickly. So the respiratory rate's higher, the end tidal CO2 value is lower. Any questions about that? So the uses of capnography, this is in Alameda County, so severity of asthma patients. I don't think we have a protocol for head injured patients here, right? Yeah, so they use it for monitoring head injured patients. And that's one of those things with controversies where you have someone that has impending herniation, and there's controversy over how aggressively you ventilate them. If you start hyperventilating them, then that will shrink the brain, but it'll also make the brain more ischemic. So you want them to, sort of be on the lower end of that, 35 to 45. You don't really want to hyperventilate them because you're going to cause ischemia, but you also want to ventilate them enough so that, the brain doesn't swell too much. So they actually have a protocol where they use it for head injury patients. I don't think we do.
No, but does their protocol specify a range that they want
It
to
does.
keep them in? Okay.
Yeah, that'll be in there. And then, the other thing, cardiac arrest tube confirmation. I think everyone uses it for that, which they should. And this is just examples of the side stream, mainstream thing. And I think these are really similar to the devices we have here. So again, the side stream one has a little bit of a delay because it's kind of siphoning it off the side, it goes through the tubing. The mainstream one actually goes through that sensor, and you can get reading within a couple seconds. So this is someone with asthma. So they talk about the shark fin thing, so I was talking about the different sort of waveforms. So people with a lot of bronchospasm or the COPD and asthma, they don't tend to have that sort of sharp part where it goes up and then it goes up slowly. The beginning of expiration is this shark fin thing, and then it goes down really quickly. And that again is seen in people with sort of severe bronchospasm or airway obstruction. Have you guys seen any of these waveforms? And then it's talking about, we were talking about the trends. That part of it is what it looks like initially, and then part of it is how is it changing. People with asthma, we were talking about the catecholamine depletion and all the other issues. So initially, people with asthma are going to be breathing really quickly, and so their CO2 will be relatively low because their respiratory rate is high. What happens is, as they get tired out, then their respiratory rate actually goes down. And it's not because they're doing better, it's because they're getting tired, they're depleting their catecholamines. So they're showing a trend, so you get someone that starts out at the top, and then at the end of it, they look like the bottom, then they're going in the wrong direction. So their respiratory rate's going down, their end-tidal CO2 is going up. These guys are getting tired. So this is something you want to be really worried about because they may, stop breathing and they need to be intubated. Any questions about that?
No, does everybody know Carrie's story? This is a case that we talk
I don't
about
know
over and
Eric's
over.
story.
It's a patient that when we first started going on this patient, she has terrible asthma, and the medics were really stoked at their treatment because